So, dear ladies and gentlemen, dear chairman, first of all, I would like to thank you to Professor Ezat for the invitation to such beautiful meeting. My topic for today is endoscopic submucosal dissection, or ESD, and what is the current status and the future. The ESD is indicated for removal of early GI neoplasia. So it means for removal of lesions which are involving the wall of the GI tract with the maximum extent to submucosis. So there is a SM invasion, and for us it's important the SM1 invasion because this is the line of curative resection, as you can see on the right side. In the case of SM1, involvement of the wall and in colorectum, there is a low risk of lymph node metastasis. So the ESD, it's a well-known method and it's respected, and we can see it in guidelines. These are the American guidelines, which tells that we should choose ESD in case of minimal or moderate risk for submucosal invasion. And recently, the European guidelines were published. It was last year. And the recommendations are divided due to the locality. Here you can see the esophageal recommendations. So when first we look at the squamous cells lesions, so we can see that the importance is the growth which is in M1 or M2, like you can see here. In that case, you can go just directly for ESD. In case there is a deeper invasion until SM1, so you should consider to do EUS or the CT scan. If it's at more advanced, the surgery should be recommended. So looking at the BORN, which is Barrett esophagus related neoplasia, the important is the Paris classification, and if there is a 2C or there is a malignancy larger than 2 centimeters or fibrosis, the ESD is indicated. The special situation in Barrett esophagus is that we also have an EMR that in some cases can be recommended. Coming to stomach, we see that there are two big groups. One is if the biopsy, I would say, is shows us the differentiated lesion, or if it's undifferentiated, like it's here. And the other question is what is the size of the lesion and if there is an ulcer. And lesions which are the most common in Czech Republic are, where I come from, are the colorectal lesions. And here we look at the JNET classification, and in the case of JNET 2B, which is predicted or predicts us that it can be the cancer with shallow submucosal invasion, so the ESD is indicated. So what is a preferable method, and we do it a lot in my unit, is the conventional technique of ESD. So you can see that a few steps. The first is marking. It should not be done in colon, but we do it anyway, so we can see the borders better of the lesion. Then we make the first cut, and we continue with the circular or semicircular cut, and we go in the submucosal space and do the dissection. Sometimes we can encounter some fibrosis, and of course we need to be careful of the bleeding control, and there is some approach to the post-ESD defect I will talk about a little bit later. I really like this technical overview which was published this year in endoscopy, and it shows us the other techniques, the special techniques besides the conventional one. So you can see that what is now quite popular is the ESTD, which is endoscopic submucosal tunnel dissections. It's preferred in the esophagus when the lesion is larger than into 3/3 of circumference. Then is the pocket creation method, which I like, and I will talk about a little bit more later. Then what is quite popular in Europe is the traction-assisted ESD. Some units use the underwater ESD, and what is very new is the intermuscular dissection, which only have been published in rectal lesions. What is used is the hybrid ESD, which means this is the combination of ESD and EMR, but should be only the rescue technique. It should not be our planned. So coming to the future, I would like to show you some, I would say, very recent data about the pocket creation method. You can see that you need to use the special hood, and then you make the incision, small incision, you cut underneath the lesion, and then on the gravity side, you make one cut, and then on the opposite side. From this Japanese experience, you can see that there is quite a significant difference between the pocket and standard method regarding the unblock and R0 resection. What is much more, I think I would say the future is this butterfly technique. So you can see that you can dissect even the large laterally spreading tumors in the rectum with the two tunnels technique. So coming to the future, I need to mention the post-ESD mucosal defect treatment. This is what I do. This is my expertise. So what I do previously was the clip closure on monopolar coagulation, but now we are using the self-assembling peptide solution, as you can see here. This is a solution which consists of the RADA16 peptide, so it means they are these amino acids in repeated sequence. And the advantage for us as a clinician is that it's in transparent, inert, non-sticky hydrogel, which is applied via the TTS catheters. The beauty is that it's activated after the contact with the biological tissue, if there is a change of pH and ionization, and these peptides start to form the nanofibers, then the network is formed and extracellular matrix. The clinical advantage is that it helps to stop the acute bleeding first. The second one is that there is a reduction of delayed bleeding. And third, this is what we examined now, is that improved post-resection defect healing. So for the defect healing, we are using the Japanese Sakita Fukutomi classifications, which shows us the 3 stages. First is active, the second H as a healing, and then the third S as a scar. You can see that there are 2 subgroups in every stage. And this is some example. This is a lesion of some older gentleman who had this lesion in the distal esophagus. We took the biopsy. There was a cancer. This is why I went for ESD. And it showed us that it's well differentiated G1 esophageal adenocarcinoma. You can see that there was quite deep submucosal invasion, but otherwise the histopathological features were negative, and the R0 resection was confirmed. And this is how I treated. This is the post-ESD defect. I treated it with the self-assembling protein, and you can see that after weeks it was very nicely healed. The same experience I had with a lesion in stomach. You can see this not so big lesions. This was the before the therapy, after the ESD, and this is after 1 week. You can see that it starts healing. This is almost healed after 4 weeks, and after 8 weeks there is already a scar. So far, we have treated with self-assembling protein nearly 80 patients. Most of them were men. Most of the lesions were in the rectum. And we treated them mostly by ESD. And you can see that R0 resection was achieved in 83%. And 80% of the lesions were benign. But more than 20% were malignant, majority of them T1 cancers. And these, you can see some examples of the lesions which I removed. So this is after EMR, and these are after ESD or a combination, the hybrid method of EMR and ESD. So we look not only only about the procedure itself, but on the adverse events, and I was quite I agreed with this that the number of the adverse event, the important one, the delayed bleeding, was low. It was about 5%, and all of these patients we treated endoscopically. The second or third day, and we applied the self-assembling peptide, or 4 times and 1 time together with coagulation. So when you look at the healing, so you can see that after 1 week, majority of the lesion was in active stage. After 4 weeks, majority of the lesions were in healing stage, half and half, H1 and H2, and almost half. And the same in week 8, when there was already a scar. Half of the scars were S1, which is the red scar, and S2, which is the white scar. And you can see that there was quite a big reduction of the diameter. And so if I would conclude my talk, I would say that endoscopic submucosal dissection is effective method in the removal of premalignant lesion and early cancer in GI tract. There are advanced modifications for the challenging lesions available already, and the self-assembling peptide gel is a novel method for post-ESD mucosal defect treatment with a lot of clinical advantages, such as it's easy to work with, it's effective in hemostasis and control of delayed bleeding, and it improves the healing of the post-resection mucosal defect. So thank you for your attention.